So the definition study came out because we were talking about which are the patients who should actually be appropriately treated with the 2-stent technique versus 1-stent technique. And we said maybe there is a way to define why DK crush is the best way of treating complex interventions. And so we wanted to define, and one of the co-authors is actually Dr. Shaiban here, along with Xiaoliang Chen and his group. And so, you know, this is something that that study came out after frank discussions over some drinks. So the bifurcation lesions can be present in different ways of patients, and I don't know whether this is going to play. Okay, so sorry. Anyway, the different lesions that you can have, Medina is the one who was responsible for classifying bifurcation lesions into either complex or not. But this is mostly for research. This is not a good way to define bifurcations. You know, so we don't know what is a true bifurcation, how bad it is a true bifurcation. But if you want to code in a research lab, this is actually very useful. So 111 or 1011 are true bifurcations, and all the others are not true bifurcations. And so we have several trials that looked at 1 stent is better than 2. Nordic trial, BK and Cactus and BBC1, and as recent as EBC as well. All of them looked at single stent or provisional stent strategy is better than a 2-stent strategy. And this is a 5-year follow-up of Nordic bifurcation study, where it said that actually you know, that both of them are equal. There's no difference between the 1 stent versus 2 stents, and obviously kissing balloon was not used that much at that time. So let's look at the DK crush studies. As you know, DK crush is going from 1 now to actually 8 is ongoing right now. So the DK crush 1 study looked at actually all true bifurcations, 111, 011 or 101. And looking at drug DK crush studies, and versus actually that is paclitaxel eluting stents. So in these lesions, most of the ones you need to understand is that whether DK crush 1 or 2 or a 3, they all looked at actually whether the longest lesion length is 10 millimeters or more. So that's when we said, okay, maybe that is a sign that actually that is how you can define complex lesions based on the length of the lesion in the side branch. So in DK crush 1, it looked at DK crush versus the classic crush, where there's too much of metal in the main vessel and you're crushing a lot of side branch stent that is brought back more than few millimeters into the main vessel and crushing it. In DK crush 2, it looked at DK versus provisional. And 3 looked at DK versus culotte, because culotte is used a lot of times in the European studies. So they wanted to look at the DK versus culotte. So then the major adverse cardiac events is at 8 months to 12 months, and obviously some of them are including even acute MIs and non-STEMIs and chronic total occlusions as well. So if you look at what is the incidence of final kissing balloon that was used in these 2 studies in crush versus DK, in crush only 76% of the times was used for final kissing balloon, whereas in 100% in DK crush. So in one of the important things also is that if you want to perform DK crush technique, you need to understand that there is probably couple of steps. As Dr. Mir Jamaluddin told yesterday, you need to do a stepwise kiss. So there are a couple more steps that you need to, but that gives you the best result. So you have to take that much time. So the amount of in DK crush 3 final kissing balloon inflation was performed also 99.5% in both the groups, culotte versus DK. But let's look at the outcomes. Stent thrombosis. On the right side is a DK, and on the left side is the whether it is whatever the control arm is. And in DK crush, actually 3, the incidence of stent thrombosis is 0.5% versus culotte was 1%. And in DK crush 2 versus provisional, obviously still DK crush 2 was not good. It is 2.2% in incidence of stent thrombosis. We know now that actually the more metal we use, the more chances of stent thrombosis. So ideally, which are the patients that we should use 2 two-stent technique is important, and defining those patients is very important. So these are the TLR rates in those patients, and still lower TLR rates at the DK crush, but unfortunately the stent thrombosis rates are much higher in the provisional stent strategy, but much better than any other type of two-stent technique that you can think of. And where is the distribution of instant restenosis in DK crush 1? It is mainly in the, if you think about it, it's mainly at the ostium of the side branch. That's always the problem whenever we think about it. And this is where the distribution, you can look at how it ends up. Either the ostial circumflex is the most common origin of the site of restenosis, but sometimes the ostial LAD could also be the reason. So the one-year outcomes of DK versus provisional in two-stent technique, it actually showed that decreased TLR and TVR favoring DK crush. The stent thrombosis rates are slightly higher. Those statistically not significant because the sample size was small. It is only about 370 patients or so. So don't go by that, but definitely stent thrombosis is much higher. Versus Coulott, DK crush versus Coulott in unprotected left main, the instant restenosis is lower and statistically significant, and instant late loss is also much lower with the DK crush than with the Coulott technique. The total major adverse cardiac events are 6% with the DK crush versus 16% with the Coulott. And there's no difference between myocardial infarction or death. And in unprotected left main, at 3 years in DK crush 3, still at 3 years, the major adverse cardiac events, stent thrombosis and TLR and MI, were in favor of DK crush as compared to Coulott study. So then that was not enough. So a larger study had to be taken, and this is about nearly 500 patients in DK crush 5 for unprotected left main PCI. It actually looked at provisional stenting. By this time, obviously definition study has already underwent some bench testing. So based on whatever we defined on the definition study, people were classified into simple versus complex PCI, and the complex lesions, and complex lesions definitely were in favor of a DK crush if you get two stent techniques. So here in the provisional stent strategy, the incidence of major adverse cardiac target lesion failure is 10.7% versus 5% in two stent technique with the DK crush trial. This is really a big study that I think opened up our eyes and said that in the United States, everybody uses DK crush as the default two-stent strategy based on this study alone. So I'm sorry for the slide, but I'll skip it anyway. So I won't go through these illustrations because we have, I'll show you a case that it can be done, okay? So the technical factors that may be important in reducing restenosis and TLR when two stents implanted in the bifurcations were high pressure side branch inflation, as we talked about, the stepwise. First inflate high pressure in the side branch, then actually deflate it, inflate the main branch again at high pressure, deflate it, then go for a simultaneous kissing balloon inflation of a medium pressure like 8 to 10 atmospheres with both the balloons or even 12 atmospheres, but non-compliant balloons or semi-compliant. And less protrusion of the side branch stent into the main branch. So do not bring it back too much and crush it against the in the main vessel. So maybe 2 millimeters is enough of the side branch stent protruding into the main branch. And obviously using imaging is very important. I think after doing so many lesions, we can simplified approach to bifurcation is a simple bifurcation is defined as in left main lesions, ostial circumflex less than 70% stenosis, the length of the lesion in the circumflex is less than 10 millimeters, and a favorable angle, whether it is 90 degrees or anything is favorable. If so, go for provisional stent alone, left main to LAD. If not, if it is more than 70%, more than 10 millimeters in length, unfavorable angle, go for DK crush study, DK crush stenting. This is a definition study that actually looked at provisional versus complex stenting, and if it is a complex lesion, go for a complex stenting, which is the DK crush technique. If it is a simple lesion, go for a provisional, which is a simplified stenting. So how do you define on the definition study? They created a major and minor criteria. One major criteria is left main distal bifurcation, side branch Diameter stenosis more than 70% of the circumflex, and the lesion length is more than 10 millimeters. In non-left main, side branch stenosis of a diagonal, for example, has to be more than 90%, and lesion length still has to be more than 10 millimeters. And the minor criteria are moderate to severe calcification, multiple lesions, and bifurcation angle is less than 45, and thrombus or a lesion length more than 25 millimeters. So any one major criteria and two minor criteria will make it a complex bifurcation. So if you have circumflex obviously calcified and more than 10 millimeters in length and more than 70% stenosis, that is a complex lesion, and complex lesion needs complex stenting, you know. So whether simple versus complex, there's no doubt. In complex lesions, do two stent techniques. In simple lesions, do provisional. I mean, unfortunately, however you try to do it in a DK Crush 2 study, what actually it showed is that if you follow the exact steps designed by the DK Crush group, you will actually get much better results. The TLR rates, stent thrombosis rates are in favor of actually two stent technique than a provisional stent strategy. In provisional stent strategy, they had to bail out in about 25% of the people with a tap technique. So that's unfortunate. That is a failure of a provisional stent strategy, in my opinion. So provisional stent strategy should be class 1 indication for all simple lesions. But if it is a complex lesion, go for a two stent technique. So whenever preferable provisional, but obviously a side branch occlusion can happen, as discussed by Dr. Shaiban, and double wire when in doubt. Complex lesions need DK Crush stent strategy, and FFR of the side branch is optional, and IVUS study is ongoing. FFR of the side branch was done by DK Crush 6 study. It did not show any superiority over a conventional angiogram assessment of the side branch. So let's, in 1.5 minutes, look at a 56-year-old man with diabetes type 2 and refused bypass surgery. He was having unstable angina. So here is a bifurcation lesion, and as you see, the length of the lesion is slightly long, and it is diffuse disease up to almost 20-30 millimeters. So then first step 1 is stenting of the side branch. Wire both the lesions, pre-dilate both the lesions if you think, or debulk both the lesions if you think that it needs, and then stenting of the side branch. And then there's a balloon in the main branch. Whether you keep the wire or not is a debate. Some people do it, but you don't need to keep the wire according to the DK Crush group. So stent or crush the side branch stent with a balloon in the main branch. And the tips of first rewiring, it has to be the proximal side branch recross. We talked about it a lot in provisional stent strategy, distal cell recross. In DK Crush, it is provisional and proximal cell recross. Then the first kissing balloon inflation, okay? And again, stepwise inflation should be followed. Then stent the main vessel here, no wire in the side branch. Then you recross, whether it is proximal or middle cell in the side branch or the main vessel stent, you can recross into the side branch easily. And then sequential post-dilatation, as we discussed about it, at high pressure, and then final kissing balloon at the nominal pressures of the two stents. So then the final result is as shown here. This will be excellent results, and you can confirm that with IVUS, okay? Anything more than 7, 8, I mean, it used to be 5, 6, 7, but in Excel studies, we have gone up to 8, 9, 10. 8 in the side branch ostium of the circumflex, 9 in the ostial LAD, and the confluence should be more than 10 millimeters. Okay? Thank you very much.
Thank you, Dr. Ramesh Daggubati, for your excellent presentation on DK Crush trial.